thank you for this invitation. I want to thank Dr. Shingata especially for inviting me, and it's a pleasure to be here. Dr. Rajapukar, of course, we met in Nadiad a few years ago
Yes,
with Dr. Desai's invitation, and had a wonderful place. I always refer to Nadiad as one of the world capitals of kidney stone disease. So it's really an honor to be invited by you today. I'm going to talk about dietary management of kidney stones. And, you know, I'm, let's see, here we are, some disclosures. Most importantly, my past medical history is that I have formed calcium oxalate stones. So anything I say about that, you'll realize that I have a personal interest in that disease process. So here's our problem with dietary therapy, and it's it was really a pleasure to hear Dr. Marocha's talk on peritoneal dialysis this morning. It's morning here in New York. I know it's evening where you are. There's only one positive randomized control trial showing the benefit of diet. We'll talk a little bit about what that trial was, but it's really, I think, important because patients are suspicious of drug therapy. You know that people are suspicious of vaccination, unfortunately, today, and patients are suspicious of drug therapy, and that really has always been an issue, particularly when I'm treating younger people with kidney stones. And since the average age of onset of kidney stones is in the 20s and 30s, there are a lot of people who are not used to taking medications. We old people like me, we're used to expecting to take blood pressure medications and statins and the like, but young people particularly want to use use diet to prevent kidney stones. So they view it as attractive because it's natural, whatever that means. Obviously, it's inexpensive and it's relatively safe as well. But we have questions about whether patients actually adhere to their diets. So if we're talking about how to use evidence in order to prevent kidney stones, then I'll say that there are three kinds of potential studies. One, we could look at the epidemiology. What are the risk factors associated with stones? And some of my colleagues like Gary Curhan and Eric Taylor have really done important work on the epidemiology of kidney stones, suggesting what risk factors are. We can also look at the effects of dietary changes on urine chemistry, and then that assumes that the changes in the urine are an effective surrogate for future stone formation. So if I eat this or drink this, urine chemistry changes in a predictable way, and we would like to believe that that change in urine chemistry will be correlated with a change in kidney stone activity. And of course, randomized control trials might be considered the gold standard for evidence, but it's very difficult to do long-term studies. It's expensive to do long-term studies of diet for kidney stone prevention. So those are some of the issues that we have to deal with. So here's an example. You know, it's morning in New York, so I'm drinking. Let me take another sip of coffee. You are all probably thinking about having some scotch after the meeting. If we think about coffee, there's a relative risk of kidney stones in these studies of epidemiologic observational studies. This is the health professional follow-up study. It's all men, Gary Curhan's study, and it basically showed that the age-adjusted relative risk for people who drank caffeinated coffee was 0.87. In other words, a reduced risk of kidney stones for every 240 milliliters of coffee. Even decaffeinated coffee had this benefit of 0.9. My own study, this is a twin study where we looked at twin pairs that were discordant. One member of the twin pair has kidney stones, one member does not. And we looked at dietary risk factors. And you can see that the odds ratio for 0 cups, there was no benefit, but the one twin who had kidney stones was at a disadvantage, or the twin that had a kidney stone had 1 to 2 cups were protective for kidney stones. 0.7 and 3 to 4 cups of coffee per day was more protective with an odds ratio of 0.6. So a reduced risk for kidney stones for people who drank more coffee. Every observational study of coffee drinking shows that coffee is associated with fewer kidney stones. And this is really quite consistent. On the other hand, people have said, well, the urine chemistry, though, goes in the wrong direction. Coffee is bad for kidney stones. And so in the effect of caffeinated studies of caffeine on urine composition, they give a dose of caffeine at 2 hours looking at urine chemistry. And you can see that the calcium creatinine ratio, millimoles per millimole, in the fasting is 0.24, and it goes up after caffeine to 0.38 millimoles of calcium per millimole of creatinine. The saturation of calcium oxalate rises as well from 2.4 to 3.1. So I'm presenting 2 options here. Would you, if you were advising your patients about whether coffee is good for kidney stones or not, would you rather take the urine studies of the effects of caffeine on calcium excretion, or would you like to take the epidemiologic data that suggests that coffee is actually protective for kidney stones? I personally find the long-term observational studies to be more compelling than short-term studies over the course of a couple of hours regarding how urine chemistry changes. But that's part of what our problem is, because I'll suggest that there is not going to be a randomized control trial for coffee. No one is going to participate in that study because it requires one group to stop drinking coffee. And if you're a coffee drinker, you're not going to do that. So I think this is an important thing to talk to patients about, because all of my patients ask me, am I allowed to drink coffee? And my answer is yes, drink coffee. I personally find that the epidemiologic data are more convincing than the urine chemistry data. And I think it's just because those are people, lots of people doing it for long periods of time. I think kidney stones are a relatively easy outcome to keep track of. You know, it's not, we don't have to really talk about whether someone had a heart attack or a stroke or something like that. We know if the patients report a kidney stone, it's a very reliable outcome. So I find the epidemiologic data more important than the chemistry data. But we are limited in the number of randomized trials. They're long, they're expensive, their enrollment is difficult. We don't always know what variables we're testing. A diet, as all of you know today, is complicated. There are many components of a diet, and if we change one part of it, we may be changing something without even being aware of what the components are. Is it the caffeine? Is it the calcium content of milk? These are significant questions. And then the applicability to non-trial subjects. In other words, can we extrapolate from the people that were in the study to other people? If we do a randomized trial in India, does that apply to people in the United States? I'll talk about one study done in Italy and the question of whether it would apply elsewhere in the world. And so there are many urine risk factors as well. If we measuring urine chemistry, we're not completely sure whether any of these, urine calcium, the urine volume, the amount of citrate, uric acid, oxalate, all of these are potentially altered by changes in diet. And whether one of these is more important than others may be difficult to know. We also think that there are promoters and inhibitors of urine in the urine that promote kidney stones or promote crystallization or decrease kidney stones or decrease crystallization. And we're not sure that we know how to measure those things. We're not sure what all of those molecules are, a variety of proteins, particularly that are promoters or inhibitors of kidney stones. And there's very good evidence that heredity is important for a proportion of these stones. And we don't know necessarily that if you have a particular mutation and we change your diet, will that change urine chemistry, or will the genotype predominate over our attempt to change the phenotype? So these are all some of the issues that I think make trials of diet for kidney stones difficult. So let's just look at some of the randomized control trials for diet and urinary risk factors. The best study, the one randomized control trial of diet to prevent kidney stone, is Borghi's study in the New England Journal in 2002. And this is the diet that I give my patients. This was a study done in patients with high urine calcium. And what they did was randomize them to a diet with an increase in dietary calcium. They also had them on a reduced protein intake, reduced salt intake, and reduced oxalate intake. And that diet reduced risk in comparison to a low calcium diet. This was really a game-changing study because it was the first trial to demonstrate that eating more calcium prevented calcium stones. Presumably that works because calcium serves as an oxalate binder. You eat oxalate. If you have the calcium in your pannier binding to the oxalate in your SOG, the oxalate and the calcium bind in the intestinal lumen. The oxalate is not absorbed by the intestine and does not appear in the urine. There are multiple studies of low urine volume showing that increased fluids reduce risk. That's not exactly diet. We understand that fluid intake, of course, will dilute urinary salts and prevent kidney stones, and there are many studies of that, including Borghi's study in the Journal of Urology. But surprisingly, a study of protein restriction alone for patients who had low urine citrate and high uric acid, protein restriction did not work. There are epidemiologic studies showing that protein, animal protein specifically, is associated with more kidney stones, and yet the only randomized trial of protein restriction had no benefit. And I'll point out as well as in our conversations in Nadiad, was that a significant proportion, I think 60-something% of people in Gujarat are vegetarians, and yet Dr. Desai has become one of the leaders in kidney stone surgery in Gujarat because there are many kidney stones in a place where vegetarianism is relatively popular. And although we're very confident that oxalate as a component of calcium oxalate stones is an important determinant of urinary saturation, there is no study showing that reducing urine oxalate in patients with dietary high oxalate is effective. So it's kind of an interesting dilemma that we have. Now, Gary Curhan became well known after this study in the New England Journal in 1993. This was the first study that showed that people eating more calcium had fewer kidney stones. So he divided patients up. This is in men. He later showed the exact same thing in the Annals of Internal Medicine in women, dividing up people into how much calcium they ate, 5 quintiles, the least calcium on the left, the most calcium intake on the right. He followed these people prospectively. So these are powerful studies because the numbers are large. The patients are followed prospectively. And you can see that the more calcium that was eaten, the relative risk of stones went down. That was really a study that led to randomized trial by Borghi showing that if you actually randomize patients to a high calcium intake, you would prevent kidney stones. The other thing that I like to point out here is that the sodium intake in these 5 quintiles of calcium was the same. Right? So in other words, eating calcium, more calcium, would reduce the risk of stones on the second line, no matter how much sodium there was in the urine. And that's a really important finding because it really showed that it wasn't the salt intake that was changing the calcium in the urine, it was the calcium intake that was important. So very critical study in men and women, leading to Borghi's study. As I told you, this study was done only in men with high urine calcium, 300 milligrams per day. It was done in Italy. They were randomized to that normal calcium diet, 1,200 milligrams per day. I call that 3 to 4 servings of calcium per day, yogurt, cottage cheese, milk, and the like, decreased animal protein, low sodium, low oxalate. And at the end, it took 3 years for the curves to separate. But by 5 years, the people on the normal calcium diet, in other words, the higher calcium diet, had half as many kidney stones as the people on the low calcium diet. So this was the end of calcium restriction as a treatment for calcium stones. But this study, first, it's small. It was started out with 60 people. They tried to reduce sodium intake, and they did that. I think the one problem is that it was not done in women. It was not done in people outside of Italy. So would this work in the United States? Would it work in India? Particularly because, at least in the United States, I think this is true in India as well, our patients are plagued by the sodium content of processed foods. In particular, there are many people who are lactose intolerant or don't like milk or think they're allergic to dairy. Do people on a low calcium intake, will they increase their dietary calcium intake? Will they take more milk or cottage cheese or yogurt or the like? And then I think we are confident that, but we didn't show. I think that in that study, the people on the higher urine calcium intake would probably have better bone density. And we think that higher calcium intake would be good. Lower sodium intake is also good for bone density. And if Borghi did that study again today, 20 years later, I think he would measure bone density. We know that people with calcium stones have lower bone density, and we believe that increasing calcium intake and lowering sodium intake is good for bone intake. So I think this study, it's the diet. It was done 20 years ago in the New England Journal. It's the diet that I give my patients, but it's one small study in Italian men. So I think this study needs to be replicated. But my own attempt to get the NIH to support such a study has not been effective. So this is really a difficult spot. Other changes in urine chemistry, and I think particularly relevant to the diet that my colleagues in Gujarat are following, is this study also done by Borghi's group in Italy, where they looked at urine chemistry and they got people to eat less fruits and vegetables. And what they basically showed was that if they eliminated in 12 people, and this is small studies limited by just urine chemistry, not epidemiologic studies, but what they basically showed was that when they had more fruits and vegetables, this is plus fruit and vegetables, this is minus fruit and vegetables, the supersaturation for calcium oxalate was higher without fruit and vegetables, and for calcium phosphate was higher without fruit and vegetables. So we know that fruits and vegetables are good. And here you basically can see that urinary calcium goes up when you take out fruits and vegetables on the right. That's because fruits and vegetables provide alkali, and alkali leads to a reduction in urine calcium. So what happened in this particular study was that urinary calcium went up when the people took away their fruits and vegetables. They did, and then in another group of people, they took people who were big carnivores, eating a lot of animal protein, and they got them to eat more fruits and vegetables for about a month. And here's what happened. The patients started on these high carnivorous diets with low urine citrate. They had very low fruit and vegetable intake to start with. And somehow, I don't know how they do this, but they were able to get these patients to eat more fruits and vegetables for a number of visits. When you eat more fruits and vegetables, urine volume goes up because fruits and vegetables are full of water. They're basically a way of increasing urine volume. That's true even for people who are drinking good amount of water. Urine pH goes up because you're eating alkali. You're eating malate and citrate and pyruvate, and citrate goes up, which helps prevent calcium kidney stones, of course. And there's a decrease in the excretion of ammonia. The alkali intake leads to a reduction in ammoniogenesis. So you can see here on the right that over the course of these visits, pretty uniformly, almost all the patients except for 2 had significant increases in urinary citrate on the y-axis as their fruit and vegetable intake went up. So fruits and vegetables are good. Vegetarians have fewer kidney stones than carnivores. And yet, India is certainly has a group of patients who are vegetarians who have kidney stones. So the answer to that question is that's not completely clear. And just to reiterate here that this high protein diet reduction here, this is Dussol in France, reduced animal protein intake because animal protein increases the amount of uric acid. In some patients, it increases the amount of oxalate. It provides acid, which leads to a decrease in urine citrate. And basically, kidney stone incidence on the y-axis in these different low protein diets was not changed by a reduction in animal protein intake. So we think animal protein's bad. We certainly believe, if to go backwards here, that animal protein is associated with more calcium and less citrate in the urine, and yet the only randomized trial showed no benefit. So again, do you believe the epidemiologic data or do you believe the urine chemistry data? In this case, I'd have to say that because this is only one study, I think the urine chemistry is pretty compelling, but I recognize that we have conflicting evidence from these different kinds of data. Oxalate is clearly an important determinant of supersaturation, but there's no study of lowering urinary oxalate to show that patients do better. The exception to that is now, there is a rare disease called primary hyperoxaluria, and now the studies of interfering RNA have turned off oxalate production. And the studies, the duration of those studies is short, but it appears that the patients have fewer kidney stones. That's a cause of hepatic production of oxalate, leading to fewer kidney stones, where the oxalate is clearly the cause of kidney failure and kidney stones, nephrocalcinosis. So I think we believe that lowering oxalate in the urine is important. From my point of view, I think if we're not going to do a randomized trial of oxalate reduction, then we can tell our patients to eat less oxalate. And more importantly, when you do eat oxalate, when you do eat peanuts or spinach, drink more water and accompany it with dairy. Have some yogurt with your spinach, have some a glass of milk after your peanuts. Then the calcium in the dairy product will bind the oxalate and reduce its absorption by the intestine. So those kinds of manipulations, increasing dairy intake based on the Borghi study and Curhan's epidemiologic studies, may be more important than just limiting oxalate intake. Curhan, in fact, though, has again done in his epidemiologic studies, showed in one study, these are 3 health professional follow-ups, men, Nurses Health Study are older women, Nurses Health Study 2 are younger women. And interestingly, if you divided the stone formers and the non-stone formers, there was no difference in their oxalate intake. So Curhan suggested that oxalate intake is not so important. And Curhan has shown that more calcium intake is important. So the suggestion here might be that limiting oxalate intake is not actually the important manipulation for calcium oxalate stones. More importantly is to try to get people to increase their calcium intake. And the best way to do that is via diet. Body size is clearly important. And so in Curhan's studies, this is Eric Taylor and Gary Curhan, the men and the women who had the greatest body mass index had the greatest risk for kidney stones. So if you compared the body mass index greater than 30 to the group whose body mass index was 21 to 23, men were 33% more likely to have stones, and women doubled their risk of having kidney stones if they were in the more overweight quintile of patients. We're not sure if these kidney stones were uric acid stones or calcium stones. As weight increases, urine pH goes down, and that is a risk factor for uric acid stones. But there's clear evidence that metabolic syndrome associated with overweight is also associated with calcium stones. So these were epidemiologic studies of kidney stones, but we don't know the kidney stone composition. Nonetheless, we know that overweight is a risk factor. And so we tell our patients that weight loss would be associated with fewer kidney stones. Is that true? Well, there's no randomized trial that shows that that is true. So if my patients ask me, how much weight do I have to lose to reduce the risk of kidney stones? We can say, here's the health professional follow-up study. Here's how much weight you had to gain to increase your risk. If you gained 2 pounds to 8, I'm sorry, this is kilos. If you gained 2 to 8 kilograms, the relative risk increased by 24%. If you gained 9 to 16 kilos, it wasn't much different. But if you gained more than 16 kilograms, your risk was up by about 40%. So I usually say to patients, losing 10 to 15 kilos is going to be associated with a reduced rate of kidney stones. Of course, people don't generally lose weight very well. It's a hard thing to do. And so when I talk about weight loss to my patients, I do that with some humility, recognizing that I'm not prescribing something easy for them to do. The other diet that has good evidence for being useful for kidney stones is the DASH diet. Of course, the DASH diet was promoted by the National Institutes of Health. The dietary approach is to stop hypertension. The main goal was to control blood pressure, but you could lose weight on this diet as well by varying caloric intake. And there's a low sodium version of the DASH diet, which led to a further reduction in blood pressure. The DASH diet has not been used to prevent kidney stones, but there's evidence that it is useful. So here I took a number of features of the DASH diet and made green something that was desirable for stone prevention and made red something that was bad for stone prevention. So examples is DASH includes lots of vegetables. Some of the vegetables are high in oxalate, like collard greens and spinach and potatoes and kale. Cereal has oxalate in it. But on the other hand, if you reduce meat intake and sweets and sugar and the like, and increase intake of potassium, magnesium, and calcium, we think those are good. So the DASH diet, if you simply looked through the diet, I've tried to code it here for whether it would be good. It has good and bad features for kidney stones. But Eric Taylor and Gary Curhan then scored patients based on a questionnaire, looked at their food frequency questionnaire, and divided the patients up based on a DASH score. They gave a DASH score based on their diet. So the highest quintile was for people who had more fruits and vegetables, nuts, legumes, that's dal, low-fat dairy products, and whole grains, got more scores, and more sodium processed meat and sweetened beverages had lower scores, the lowest quintile of patients. So they scored the DASHness, and then they looked at whether those patients had kidney stones. And the more DASH-like the diet, this is on the x-axis, quintile 1, the least DASH, the most carnivorous, less fruits and vegetables, going to the right, where the fifth quintile was the most DASH-like diet. Patients had fewer kidney stones. So this is not a randomized trial, but it suggested that the people who followed a DASH-like diet had fewer kidney stones. And when they looked at urine composition, it wasn't completely clear why the people on the DASH diet were at lower risk for stones. One issue was that the more DASH diet, as I suggested, had more oxalate, more spinach, and more fruits and vegetables. Well, some of that's oxalate. On the other hand, the citrate was a little bit higher, statistically significant, more citrate in the urine. So the suggestion here is that, again, vegetarians may have more oxalate in their urine because they eat more oxalate-containing fruits and vegetables, but they also will have more citrate, and their urine volume's higher because they're eating a higher water intake and therefore having a higher urine volume and diluting their urine. So the DASH diet has not been used in a randomized trial, but appears to be useful for kidney stone prevention. I'll just point out that thiazides work very well. Thiazides reduce urine calcium, and in these 3 studies of chlorothiazide, chlorthalidone, and indapamide, there's no question that thiazides work. And so the issue then would be asked, what's the easy choice? We had this debate at the American Urologic Association 2 years ago. Meds, diet. What's the easy option? There are certainly older people who think, give me that pill, I am not going to change my diet. And there are younger people who say, no, I don't take pills, I want to follow a diet. So sometimes this is a discussion to have with your patients? Do you want to take a pill like potassium citrate or chlorthalidone to lower urine calcium? Or do you simply want to try diet, which may be more complicated and may be facing more adherence problems for some patients? Now, I want to talk about 24-hour urine collections, because when we were in Nadiad several years ago, Mahesh Desai was interested in setting up 24-hour urine collections. And at that time, I was there in Gujarat to sort of help talk about that idea of doing 24-hour urine collections. But I've actually changed my mind a little bit. I'm not completely opposed to doing them, but I know that in places where I've lectured, in India, in China, and places, Australia, New Zealand, they don't always have 24-hour urine collections available. So we wrote this paper in the Journal of Urology. I was the one nephrologist. There were 3 urologists here. And we talked about the pluses and the minuses of doing 24-hour urine collections. You get good data, and patients like to know what's in their urine. It's more convenient than it used to be, and allows you, particularly if you're talking about diet, it allows you to talk about which part of the diet is relevant to your patient's problems. Your calcium is high, your sodium is high, your oxalate is high, your citrate is low. You can talk, instead of giving them a more complete diet, you might say, let's focus on this one urine variable. But of course, there are urologists who think it's difficult to interpret the results. You have to do it over and over again to see if things change. There's a cost to doing it repeatedly. So we wrote this paper, empiric therapy for kidney stones. And I really was thinking about my trip to India, but it's also true in New York City, where in my crazy country, some people don't have health insurance and can't do a 24-hour urine collection.
Balance kar rahi hai.
Therefore, so this was a empiric therapy. The idea was to do treatment without a 24-hour urine collection. And those empiric therapies without urine collections are weight loss, we've talked about, water, coffee, juice, beer, more fluid intake, up to 3 liters per day, the Borgi diet or the DASH diet. These are things you can prescribe whether or not you have a 24-hour urine collection. And you can prescribe potassium citrate or potassium bicarbonate. And we as nephrologists are comfortable writing for thiazides. We use thiazides all the time, chlorthalidone and indapamide. You don't have to have a 24-hour urine collection. You can give those drugs to lower urine calcium. If it's already, let's say, a normal number, you can make it more normal. I don't ever say to a patient, your urine is normal. If you're having kidney stones, I say, it may be normal, but let's make it more normal. And you can prescribe bisphosphonates because people with calcium stones have low bone density as well. So these are empiric therapies. Water is intuitive, it's inexpensive, it's accessible, it's over the counter. It doesn't need a prescription. Beer, clear sodas, also reasonable choices. Reducing sodium intake, I tell my patients, will prevent stones, will extend your life expectancy because your blood pressure will go down. You'll have fewer heart attacks and strokes. Will improve your bone density as well. Increasing dairy intake prevents stones, improves bone density, and reducing animal protein intake prevents stones, prevents COVID and global warming, right? This is, part of the topical nature of talking about animal protein intake. And finally, we did this as Ryan C., a urologist at Vanderbilt in Tennessee. I'm a co-author on this study that was published in Urology last year, where we looked at patients who received preventive therapy for kidney stones. Empirically, no 24-hour urine collection was done, versus selective, meaning that they were treated based on the 24-hour urine result. And amazing, controversial, at 2 years, there was no difference. Whether you were treated empirically or selectively, based on a 24-hour urine collection or not, there was no difference in emergency room visits, admissions, urologic procedures, or any adverse event. So the questions here, what's the optimal effective diet for prevention of calcium stones? Weight loss is hard, but it addresses cardiovascular risk factors. The Borgi diet is the only randomized trial. The DASH diet looks very good. People who have more DASH diets have fewer kidney stones, but it's never been done in a randomized trial. What's easier for some groups of patients, diet or thiazides? I think we should do a study of diet versus thiazides and look to see whether thiazides, which are clearly useful, and diet, which is a little bit more difficult, which is better. And what about bone density, which is obviously a very important risk factor for patients with calcium stones? We want to show that diet improves bone density, thiazides improve bone density, and I think we need to document that that's true in patients with kidney stones. So I really appreciate your attention and my opportunity to discuss this with you today for this August group. Thank you.